How did you end up becoming a nurse?
Well, it's a very strange story. I went down to the lawyer and I was very shocked when I walked into the lawyer's office, and as soon as I sat down, he reached under his desk and took out a worn leather Bible and said, "If you put your hand on this Bible and swear to me that you'll become a nurse, I'll do your divorce for nothing."
Wow.
And so that's the moment I decided to become a nurse. As human beings, we learn through mimicry, but we are seeing right now a definite difference in the physicians than we did 20 years ago. They are partnering much more. They're not buying into that hierarchical mentality. HROs, which are high reliability organizations like an operating room, these require trust and they do not have a hierarchy. It is everyone's responsibility to speak up. So when you're in a hierarchy, you are in fear. One group is always oppressed, the group below. So we have to shift from that model to a model where the patient is at the center. Healthcare must be local. It can't be from Washington, D.C. Because the needs of every zip code are different. Nurses heal body, mind, and soul. What a nurse does is partner with the patients. It's that relationship that heals. It doesn't matter if the diagnosis is that cancer came back. There can be a healing relationship. I'm not healing the cancer. What I'm healing is I'm providing healing for the patient.
Welcome to the Nurse on Purpose podcast, where we challenge media stereotypes about nursing and spotlight the incredible and diverse roles nurses play in healthcare. I'm your host, Nello. Every week, I'll be joined by a nurse who is reshaping the narrative. From frontline care to leadership, education, innovation, and beyond. Our aim is to show the world that nursing is so much more than what we see on TV. Together, we'll explore how we can collaborate with media and other stakeholders to create authentic and inspiring portrayals of nurses. Let's begin the conversation and ignite change, one episode at a time.
Welcome back to the Nurse on Purpose podcast, where we challenge media stereotypes about nursing and spotlight the incredible work that nurses do every day. Today, I have an incredible guest who has dedicated over 2 decades to advocating for the nursing profession, Kathleen Bartholomew. She is a renowned speaker, author, and expert on nurse culture, communication, and leadership. And Kathleen has worked tirelessly to address nurse-to-nurse hostility, strengthen nurse-physician relationships, and create cultures of trust in healthcare. Kathleen believes that with 5.3 million nurses in the U.S., we have the power to transform healthcare, starting with how we support and mentor one another. But her vision goes even further. Kathleen is championing a bold new model of healthcare, one led by nurses, focused on wellness, holistic care, and disease prevention based on social determinants of health, rather than the current reactive disease response system. She advocates for the adoption of the public utility model in healthcare, a system designed to prioritize patient well-being over profit. And I'm so thrilled today to welcome Kathleen Bartholomew to the podcast. You're welcome.
Thank you very much. Pleasure to be here.
Thank you for being here. In today's episode, we're going to just dive into all of this, how your journey in nursing started, and then move forward to discuss how we can reshape nursing culture, we can redefine healthcare delivery, and reclaim our role as leaders in patient care. So let's begin first by talking about your journey in nursing. How did you end up becoming a nurse, and what roads have led you to this point in your career?
Well, it's a very strange story because in 1991, I had been going to marriage counseling for 2 years, was 36 years old. And one day my husband came into the kitchen, poured himself a cup of coffee and said, "I took a job in San Francisco. I'm leaving on a 6 p.m. flight," and left. Then I went into my job at the telephone answering service and I was clearly upset. And one of the customers, who was a regular named Bob, said, "What's the matter?" And finally I told him that my worst fear came true. I was going to be a single mother of 5 children living 3,000 miles away from my nearest relative. He immediately reached into his back pocket, took out a check, wrote a check to a gentleman named Miles McAtee, folded it and thrust it into my hand, saying, you're going to need a good attorney. I thought, this is silly, and I tried to give it back to him, but he didn't. And I tried again, and he didn't. So I folded it up and I put it in my jeans. And long story short, in about next month, I went down to the lawyer, and I was very shocked when I walked into the lawyer's office, and he said, sit down. And as soon as I sat down, he reached under his desk and took out a worn leather Bible. He put the Bible on the corner of his desk and said, if you put your hand on this Bible and swear to me that you'll become a nurse, I'll do your divorce for nothing. Just that check that Bob gave you. Wow. And so that's the moment I decided to become a nurse.
Wow. Why did he make such a statement?
That's a great question. I didn't find out the answer to that till 10 years later. I ran into Bob at a store, and he said that Miles owed him a favor, and he just started rambling about how he was in the hospital. Bob was in the hospital, and how great the nurses were and how much he appreciated them. And I thought, great, I'm a nurse because Bob loves nursing. But, so I felt like a failure when I was 36, but now that many decades have passed, I realized that coming into the profession of nursing at 39, almost 40 years old, is very different than entering it in your 20s. And I saw things that I wouldn't have seen had I spent those 20 years in nursing. I mean, I saw the power dynamics between physicians and nurses and said, wow, this isn't normal, and saw the nurse-to-nurse reactions and questioned everything. So it turned out to be perfect for me to enter later in life.
That is such a wonderful story that somebody told you to to take an oath on the Bible.
I mean, he just said, sit down, and that was the next sentence. There was no niceties at all. I mean, it was a 5-minute appointment.
Wow. That's awesome. And did he kind of follow you through your journey in nursing from that point? Or
not that I know of. I moved 3,000 miles to be with my aunt in North Carolina, so I wasn't even on the West Coast for the next several years.
Yeah. And after nursing school, what unit did you start your practice?
I started in a small community hospital for 2 years. We had everything. And then after 2 years, I went to skilled nursing for less than a year before I was laid off. And I came right back to Seattle, where I was a per diem nurse and worked 40 hours a week for the next 4 years, all around the hospital. But within the first 3 months, it was very clear that I wanted to be on the neuro unit. And the reason I wanted to be there is not because I was in love with the neuro profession. It's just because the camaraderie of the nurses and their relationships with the doctors was so... I just wanted to be there because I wanted to be around that. They were so supportive. I mean, so supportive that in the middle of a shift, if I was covering for another nurse and that nurse was at lunch and I developed a relationship or a rapport with their patient, when they came back from lunch, I could say, will you switch with me? And they would. I mean, just like that.
Wow.
No questions asked.
Wow. How much does that boost your morale and make you want to go into work every day?
Right. And I was determined to create that. I mean, now that I knew what it looked like, and, most people say it's a direct result of management, but to be honest with you, the manager wasn't there ever because she was managing 4 units. It was the people who had been there for years, and they had created this culture of supporting and nurturing each other, and especially new people. And so that was wonderful. And I still am friends with the physicians to this day.
Yeah. That is amazing. It shows that we don't have to wait for anyone to help us create a supportive working culture. We can do it ourselves, within ourselves. We don't need to wait for a professional organization to say, okay, take this course on civil behavior. This is something that we can intrinsically begin to institute in our healthcare organizations. In your TED Talk, Lessons from Nursing to the World, and in your article also, A Care Plan for Nursing, you highlighted both the honor of being a nurse and the hierarchy that exists in nursing and healthcare. And now, even when you were speaking, you mentioned twice the physician-nurse relationship and how in one arena you saw it as negative, and in another, like the neuro unit, you saw it as positive. Can you talk about why dominance in healthcare exists and how it trickles down and may lead to horizontal hostility among nurses?
Sure, yes. It comes from 100 years ago, where men were more superior to women, where physicians came from the upper class and nurses came from the middle class. That history is very important. When I was talking once at a Nurses Day event, I said there was a nurse who had been a nurse for almost 50 years. And I said to her, "What's your very first memory of nursing?" And she said, "Well, on my very first day, I thought I was totally prepared." She said, I thought I had everything. And then as soon as I get to the floor, the doctor takes out a cigarette and I had forgotten my matches.
Oh
She
my
was
goodness.
expected to light his cigarette. So then I said to the audience, "And then what happened after that?" And they were like, "Well, another decade passed and you got coffee. And, another decade passed and you gave up your chair. Another decade passed." And I said, "And then what are you doing right now?" And the nurses were silent. I said, "It's so hard to see what you're doing right now," until one nurse said, "Well, when the doctor doesn't feel like putting his orders into Epic, I do it for him." Or another nurse said, "I don't want to bother the doctor on the weekend, so I take the risk of writing the order and then he signs it on Monday." So it's, this is not about our nursing profession. This is about our world. This is about the culture of the United States. And as we can see, that hierarchy isn't working anymore.
Yeah. Wow. This really does hit me to my core because it feels like there have been changes, but it doesn't seem large enough. There's still so much, what I call it, like hierarchy driven
Well, it's
hostility
because
or
it's
business.
yeah,
Yeah.
because it's taught.
Yeah.
Okay, so because we learn as human beings, we learn through mimicry.
Yeah.
And when the physicians come into the room, that they're taught by physicians. But you are seeing, I mean, we are seeing right now a
Mm,
definite difference in the physicians than we did 20 years ago.
mm,
They are partnering much more. They're not buying into that
mm.
hierarchical mentality,
Absolutely.
even though they're being treated like that.
Yeah. Yeah.
You have to realize, I mean, look what we do to residents. It's abusive.
Yeah.
Why would we expect, residents to be
24.
awake for 24 hours taking care of patients?
Mm.
I mean, and let's talk about the resident who took her own life last. I mean, suicide in nursing and in physicians
Yeah.
is high.
I'm sure that there are practical steps that nurses can take to really break that cycle of hierarchy. And you said the culture is shifting right now.
Hmm.
But what can nurses continue to do to create a culture of respect and collaboration among our physician partners and among our peers and among with the patients and with the public?
Okay, so my answer to that is they can stay in their own power.
Mm,
They can claim their own power all the time. And let me give you examples. I call a physician at night. His voice is dismissive and gruff. I know I've woken him up in the middle of the night, but yet he's the physician on call. I need
mm,
pain medicine. There's not enough. My patient's pain has not been relieved, and I've tried everything for the last 4 or 5 hours. But when
mm,
I call, he's very dismissive and hangs up the phone
mm,
after he gives me an order. So do you
mm,
let that slide?
mm,
No. You wait in the morning, you say, "Excuse me, Dr. D, may I speak to you for a minute in private? When I called you last night, I realized that you were sleeping and I woke you up, but you were on call. And I didn't appreciate
mm,
your tone of voice or slamming the phone down. It's not like I called you for a stool softener. I called you for some much needed pain medication only after I had tried everything else. I would
mm.
appreciate it if you didn't talk to me in that tone of voice again."
That's amazing. So, what you said is stand in your power. A lot of nurses feel afraid. They feel like we've been taught in nursing schools how to address physicians and how to kind of the proper decorum. And that's not really where we should have focused our energy. We should have been focusing our energy in how to say no, how to be assertive, yet respectful, and how to make sure that there is mutual consideration for every
Right.
discipline involved, right?
Just remember that communication is squashed in every hierarchy. So if you're taught to that somebody is more powerful or worthy than you, then communication is silent. So HROs, which are high reliability organizations like nuclear power plants, the top of an aircraft carrier, an operating room, these require trust and they do not have a hierarchy. It is everyone's responsibility to speak up. So when you're in a hierarchy, you are in fear. You hit the nail on the head. You are in fear, and one group is always oppressed. The group below is always oppressed, right?
Yeah.
So we have to shift from that model to a model where the patient is at the center. And it doesn't matter if I'm the doctor, the nurse, the cleaning lady, the housekeeper, the security guard. I can give you stories right now of a housekeeper that saved a patient's life on my floor, of a nursing assistant who saved a life on my floor, of a dietary error that almost killed a nurse on my patient on my floor. Wow. So you can be the best doctor in the entire world, but if that post-op care, you don't have, here's an example. If you do an anterior cervical surgery and your patient is in a hard collar and dietary sends up the wrong tray and the patient chokes and turns blue and passes out, it doesn't matter that you did a great surgery, right? So we have to, it's very clear, and this is what we're not taught, and it's not emphasized, that you're a team. And just like in an airplane, for example, your co-pilot has a responsibility to speak up if they even get a gut feeling that something's wrong.
Yeah. Absolutely.
It's not a mother may I game.
Yeah, absolutely. And like you've said, when a dominant group exists, it exerts so much power downward, and the oppressed group cannot direct its power upward. So what does it do? It unconsciously starts attacking one another horizontally. That's what has been going on in nursing as well.
Right. So let's talk about the easiest way to shift that. The easiest way to shift that is when you are in a hierarchy, you value your own psychological safety more than anything else.
Okay.
And that's why you don't speak up or you don't act. That chooses your psychological safety. Dr. Brian Sexton did work at Duke University showing if you assess and you decide it's not worth the risk, okay, to yourself. Yeah. So, but when you have a circle, which I call a tribe or a community, you have the patient at the center. What you value the most is the patient.
Yeah.
So if you ever want to switch from one to the other, here's an example. I'm up in doing a webinar for a large surgery center in New England. And they want patient safety as the topic. And you can be assured that if somebody's calling me asking me for patient safety, it's because someone's died.
Yeah.
I mean, that happens all the time. They wait until there's a big medical error or a series of errors, and then they'll call because the board usually requires it. So during the call, I find out that the person who's hiring me has their cell phone on and uses it in the operating room. And so I said to that patient, now, you married? And they say, yeah. And I said, well, imagine your wife comes for a complicated surgery tomorrow to the operating room. Is it okay if all the nurses and the doctors have their cell phones? And he said, no. So that's the marker. So when you decide whether to speak up or not, the only question to ask is, what if that was my child? What if that was my husband? Would I speak up then? And you darn will. The answer to that will be yes every time. And that is the marker for which I live by. And that's why I don't hesitate to speak up. And it doesn't matter what it is.
And it's all about the patient's safety. And it's about protecting the integrity of our profession, the oath that we took to protect our patients and to nurture our profession. So when you think about those things, in addition to considering if that were a family member, how would I respond? You kind of develop the boldness, put all those things aside, you forget about the hierarchy, and you speak with confidence because your voice matters. And the more you silence your voice, you keep yourself from speaking out, the more people and other professions will look at you as if you don't have an opinion and you don't have a voice when you have a voice, but you just refuse to use it or you're scared to use it.
Right. And quite frankly, just between you and I and everybody who's listening, I think being divorced had something to do with it. Because after I lost my home, my job, my house, my husband, it was like, what can you take from me? I have nothing to lose.
Yeah. That's amazing. It empowers you, even though it's a tragedy, it empowers you in that way that you can either fold or you can rise and become like this new emergence of yourself. And I think that's what I see here kind of playing out. And I appreciate your boldness. I appreciate your confidence and your fierceness to not back down from this fight. So we are going to shift gears now and really talk about this adapted public, utility model for healthcare. Because I was reading your article and I found this really fascinating. You said that the US, we don't have a healthcare system. We have a disease response system. And you are right, right? Over 50% of Americans are suffering with one of the top 5 chronic diseases. We are in the trillions in our healthcare spending, and yet we still suffer from poor health outcomes than other developed nations, and our life expectancy continues to decline. So can you talk about this model and how you propose that we shift toward a true healthcare system that is focused on wellness and prevention instead of disease responsiveness?
I'd love to. Imagine that nurses were in charge of healthcare for a community or a zip code in the United States. What would they do? They would go in and assess the community. They would do an assessment. It would be a nursing assessment. Then they would take that assessment and they would share the results with the patient, who would be the community. They would work with the stakeholders and they would look at what resources are there, and they develop a care plan for the community. And they would, because healthcare must be local. It can't be from Washington, D.C. Because the needs of every zip code are different. And because the other thing is because relationships matter. And the precious time that both physicians and nurses have with their patients has been minimized. And we have been given task after task after task, and we're task saturated. Nurses feel like Lucille Ball. I don't know if you ever saw her in the chocolate factory. There's this little video of all the chocolates coming out so fast, and she puts them in her hat and her clothes and her mouth, anywhere. And that's what nurses feel like. So we need a different system. And I think the biggest message that I'd like to get across is the research by Donna Bedian that says, the structure dictates the process, which dictates the outcomes. Now, you just beautifully summarized the outcomes of what the health is like in the United States. And yet, even on a governmental level, we've got people changing the processes. Oh, let's do value-based. Oh, let's do this. Oh, let's do that. But that's not the problem. The problem is that the structure in healthcare, we're structured as a business. And there are many people making billions of dollars on sickness. Okay?
Yeah.
And because of this is not aligned with the values of either nurses or physicians, that we profit on disease.
Yeah.
So until we change that, nothing is going to significantly change. So how do you change that? Well, you look at models that have worked. Public utilities are something that's uniquely American. And Roosevelt said, if, quote, and there was a precedence for this too. In the 1940s, he said, if there's a essential service, and he was talking about electricity, if there's an essential service that people need, you can't deny it, and it's exploited, then the public has a right to take it back. Okay, so we have a right as a public to take it back and make it local. But, there's some public utilities that are moneymakers. Yeah. So that word does not resonate with people. So that's why we say the adaptive public utility model, because this is transparent and it's owned by the community. And the social determinants of health, like the infrastructure that we need to create a healthy community, is what? Well, I don't know. It depends on the assessment. Maybe it's a daycare. Maybe it's a skateboard park. Maybe I need to put a nurse practitioner into my middle school. I don't know, but I would know. I mean, because when you look at the fact that over 41% of Americans are overweight, one of the best things you can do is focus on nutrition. What if I put a nurse in the supermarket in one of the aisles? No, not a nurse, a nutritionist in one of the aisles, so that when you're coming through with your cart, you think you're giving a great, healthy meal to your teenager as they're going off to school. You get them a green smoothie and a yogurt, and you don't realize that, oh my gosh, that's 70, you just sent your kid off with 72 grams of sugar. That's more sugar than I have in a month. Right? And but so there's an education deficit. And not only that, nurses are holistic. So you look at the fact that you would not have bottled water in this local town, because you would explain to people that there's 70,000 nanoplastics in each bottle of bottled water. You wouldn't have Keurig coffee makers where boiling water goes through plastic.
Yeah.
You'd educate, you'd have somebody who's in charge of the environment. Physicians and nurses would partner in a collaborative clinic with a nutritionist and a behavioral health person, and that team, which has already been shown with 22 years of research from the University of Washington in their AIMS model, the team has already demonstrated that they can change outcomes. Yeah. The real problem is money. I mean, yeah. I'm washing an old man's back. I tell this story in my TED Talk, but I was washing an old elderly patient's back when he burst into big sobs, and I jumped back and said, "Did I hurt you?" No, he says, "Go on," right? So I wring out my washcloth and I give him the tissues, and he's calming down, and finally I hear him say, "I'm sorry. It's just that my wife died 22 years ago and no one's touched my back since that day." What's the billing code for that moment? What's the billing code for unbottling 22 years of grief? Wow. What's the billing code for the physician who doesn't give a blood pressure pill but listens to the story and gets some support for the woman or why her blood pressure's off the roof? What's this? I come into a patient's room and the nursing report was, quote, "the dead baby's on the nightstand." And I said, "What?" And she said, yes, she lost the baby. She has no relatives or friends or family. She won't let us take it, and she won't hold it. That's your problem. You do it. Figure it out. Night shift said to me. What do I do? What's the billing code for creating the relationship, that healing relationship, where by the time my 8-hour shift is over, I can dress the baby and get the mother to hold the child? What's that worth to you? So let's get to the real key, and caring, healing, these healing moments that everyone in your audience has. Yeah. They're not worth anything in today's society. Money is. And how this plays out, let me give you an example. If I walk into a group of nurses and I say, imagine this is the nursing profession, and I draw a line right here. What is that? They will all say skilled nursing or rehab. Yeah. Rehab, then med surge, then orthopedics, then L&D, then tele, then step down, ER, OR, and at the top is ICU. Okay, now let's just look at that for a minute. Why is ICU at the top? If you can run 7 pumps at the same time, but the person at the bottom needs somebody who has 7 months to stay with them until they can walk again after a stroke or talk again after a stroke. So this plays out in physicians, where neurosurgeons and cardiac surgeons are at the top, and this is why everybody's leaving primary care. This is what you're looking at, and what we're living through is a shift in values. We need a system that elevates the values of healing and caring, the value of humanity, where it's just as important, where we recognize that it's not like there's a science to our profession and an art that it's like this. Yeah. It's yin and yang. It's left and right brain. I mean, we even call the right brain the lesser.
Yeah, right. It's like the artsy side of the brain.
The inferior, hemisphere.
Yeah. Wow, that was powerful. I feel like I'm at your TED Talk again.
Oh, I can't, sorry, I did recap some of it, but it just makes the point for the model. So you were asking about a model. There's precedents that's set. What if nurses, just keep thinking to yourself, what if nurses, led healthcare? Yes. What if nurses, what would it look like? What would it look like? And I'm so frustrated when we're split as a profession. We're split because, the people, our chief nursing officers belong to the Organization of Nurse Leaders. And so our alliances become split because then there's 2 goals. The hospital wants to make money. Well, for example, a CFO was giving me a tour of his hospital. At the end, I said, "Where does everybody work in this town?" And he said, "Well, they work here at our hospital." And I said, "Oh, well, what's the plan when the communities kept healthy. What will you be doing with these beds now? And he said, what? I don't understand your question. Right? Okay. So if physicians
Like
are
that is
going,
not the plan.
right. So what I'm saying is they're not going the same direction. Nurses want to keep everybody out of the hospital. Okay.
Right.
So you don't partner with somebody. If you're going east, you don't partner with somebody who's going west. And this creates a dichotomy. When a nurse becomes a manager, you'll hear nurses say, she's one of them now. What does that mean? It means that her allegiance has switched. So we've got these two goals, and we can't serve these two masters. Make money and,
Yeah.
keep people out of the hospital and then keep them in at the hospital at the same time doesn't work.
Yeah. Because we're thinking people over profit.
Right. So we're splintering ourselves as a profession. And you wanted to talk about also, one of our major problems is that the general public doesn't know what we do.
And we're going to
They don't understand our role. If you say, I think we talked about this earlier.
Yeah.
It's called a meme for society. It's called a cultural meme in sociology. In sociology, it's called a cultural meme. So firemen fight fires. Teachers educate. Police keep us safe. Nurses.
Define.
What's the answer?
Yeah.
Because until everyone can answer that question, that simple sociological phrase, we will never be elevated to a position where we have the opportunity to heal Americans.
So let's talk about that, right? Because, you just stated that, until we can define nursing clearly and what we need, we won't get to where we need to be in terms of like the respect that we deserve and the ability to heal our community. If you could craft a definition that captures the essence of nursing, what would it be?
Nurses heal body, mind, and soul.
Nurses heal body, mind, and soul. The word heal can sometimes be intimidating. I've told another one of my guests that nurses heal, and you just echoed that sentiment. But she said, when you say nurses heal, it puts the responsibility on the nurse to heal that patient. We can treat them, but it's not our job to heal them. Like we don't have a say-so in whether they become healed.
Yeah, I don't agree with that.
Yeah.
So I don't agree with that because what a nurse does is partner with the patients. And the patients and the nurse. It's that relationship that heals. It doesn't matter if the diagnosis is that cancer came back.
Yeah.
There can be a healing relationship. I'm not healing the cancer.
Right.
What I'm healing is I'm providing healing for the patient.
Yes.
I'm partnering with the patient. You all know that you have to meet somebody on the same level, same vibe. You're right there. Why can one nurse create a relationship with a patient and the other one can't? Probably because of your experiences. One nurse maybe was in that situation and she can really relate to what that person's going through, right?
Yeah.
And it's that relationship that heals.
Yeah.
So we're not talking about, everybody's so focused on what the disease is. But the act of what we do is healing.
Yeah.
And we don't just look at the body.
Yeah.
We look at everything. We notice that there's no cards in this patient's room, that they haven't had any visitors, etc.
Why should nurses lead the charge to transform healthcare?
Because we don't have a vested interest in making money from patients being sick. Everybody else makes money from it. We're actually the oppressed group in nursing. In this business model, nursing is the oppressed group. We come with the room. We're not, you can't even identify the cost. It's like getting the hotel maid with the price you pay for the hotel. Right. Our services are invisible. And then this charting that we do, this copious amount of charting, it wasn't even designed by nurses. If it was, it looked totally different. Do we need AI? Yes. Do we need to search for patterns? Yes. Does 90% of our time need to be spent charting? No. Why is it I can go into the dentist office a decade ago and they can say, hold on, just be quiet for 1 second because I'm going to read your assessment. And they assess your teeth and it's already recorded. Why can't I do that with my patient? Why didn't I do that a decade ago with my patient and not have to chart?
Yeah. Yeah.
What would charting look like if it was designed? What would technology look like if it was designed by nurses, to support nurses? And getting back to what you said, to say heal requires a lot of self-esteem.
Yeah.
Okay? And it requires owning what we do. And I'm not saying that that's the best answer or the ultimate answer. My point is, I want us to come together and have an answer.
Yeah.
That's it. That's my whole point. Doesn't matter to me what it is, I mean, that's my best shot. But, what matters is that when I ask 1,000 nurses to answer that question, I get 900 different answers.
Mm-hmm.
Okay, so don't write another peer-reviewed paper about it for nurses. Who needs to be educated is the general public.
Yeah, absolutely. What needs to change for nurses to take the driver's seat in shaping healthcare policy, for instance? What needs to change?
Nurses need to realize there's nobody in that seat and move over and take it.
Yeah. Don't wait to be welcomed to the table or invited to the table.
No, we don't even need to be invited to that table because I don't want that table.
Make our own table.
I don't even want a table. I want a partner. I want a circle with my physician and my community holding hands and surrounding the most vulnerable in my town. I want to be known as a town that takes care of the elderly, the young, and the vulnerable. I want the values of nursing, to be obvious, and that I want caring to be valued.
Yes. Wow. My goodness, my audience is going to have a field day. They're going to enjoy this episode so much. I want to just briefly ask you exactly how this public utility model would work. And under this model, how would communities reinvest any healthcare savings into other arenas like education and housing and public health initiatives? Tell us briefly what exactly, how would this model work exactly?
Sure. I just want to let you know that Dr. John Silver is the originator of this model, and that he'd be a wonderful guest for you who could answer all questions specifically. I could give you the general overview. Okay. But how it works is that it's housed in the universities, and we have a collaborative group. You start with collaboration, so you have physicians, nurses, social workers, EMTs, the hospital. They all come together, and this group is the one that does the assessment and looks at what the town needs. And because you're aligned with the university, you use best practice. There's not this 17-year gap between them deciding that a drug is not okay and people still using it in practice. So you get to spend the money. I would say that the role of government then becomes to give me information. I want to know in my zip code, please tell me what is sucking up most of my healthcare dollars. What are the top 2 diseases? I would target those diseases with education and prevention. I would use the savings that happen within a year. You should start to see savings, and within 2 years, huge savings. Then you go back to the community and say, what do you want to spend this on? It looks like that we have a lot of homeless people coming to our area, or it looks like drug addiction is becoming a problem, or these are the statistics we have. And then the community owns healthcare, and people start owning their own health. Okay? And we use the many innovative strategies that nurses are already developing all across this country. We look at what best practices. We use AI to create a platform. We already ran a pilot study of this in Spicewood, Texas. We took we put a nurse practitioner and a nurse into a food bank that was open 1 day a week. When people came in, we created 41 care plans. We changed that food bank from a revolving door to an escalator, where we lifted people up. Within 3 weeks, people were returning canned goods. We had thought that most of the people would be coming who would be elderly. We were shocked at the fact that the most people who came were from 29 to 40 years old. We weren't prepared for that. They weren't on Medicare. They weren't on Medicaid. They were hungry. We paid attention to relationships. We focused on relationships. When somebody came to the food bank and they had newborn twins and they were exhausted, we'd take another member of the food bank and pay for them to clean their house so that people felt valued and had jobs. We wove that community together. And I can give you examples from that, but I know we don't have time. But John, I know that Dr. John Silver and I would be happy to come and speak to you more about how the model works. That's the overview. I mean, you imagine that you have a water plant, right? And if you have water, which is a public utility, then you need a place to keep the water. You need pipes to bring the water. Well, the same thing is for healthcare. You need to have the physical structures. Everybody has to have a primary care physician or nurse or a nurse practitioner. That's first. Okay? Everybody has to have a nurse practitioner. That's the first thing you would do. You know, and then the next thing you would do is you'd move from that to, you know, what structures do we need to put in place in this community to address the needs of this community? And then you put the template you're using online so that any zip code in America, that's what Nurses Transforming Healthcare is doing. It's a nonprofit raising money to do a template for what would a nurse-led healthcare system look like in one zip code. Because if you can create this model in one zip code and put it up for free, then any zip code in America could copy it. What if every nurse had their own NDI number and could charge? And you could take all the money. Here's another example of how you could roll it out. You could take all the Medicare and Medicaid money. I'll just take my zip code 98926. You could take all the Medicare and Medicaid money and put it in a separate fund, and you could use that fund, and you could say to CMMI, which is the Center for Medicare and Medicaid Innovation, you could say, hey, at the end of 2 years, you don't get to say how we use this money. We're going to use it the way we see fit. But at the end of the 2 years, we're going to reinvest the savings back into this community, and we promise you that every year it'll be less and less and less. And you get to watch what you should be paying for in a healthcare system instead of reacting, you know?
Right. High health insurance costs.
You don't need a health insurance. You don't need health insurance. No, so what would happen in a public utility is the community would buy health insurance for the high risk patients, but everybody would just pay like you do for your electric bill. You'd pay $150 a month, and then that's it. No copay. No insurance, because your zip code has the insurance.
Yeah. This is communities taking care of each other. Oh my goodness. I would love to delve into this even deeper because it really captures the essence of our training as nurses to take care of our communities and to think people's health over profits, you know.
Right. Nurses have the knowledge, the skills, and the compassion. You asked earlier, why nurses? Because we have all three.
Yeah.
That's what I love about this profession. It's heart and soul.
Yes.
Mind and heart. We have it both.
Yes. That's wonderful. Oh, man, I've so enjoyed speaking with you.
Thank you. Thanks for asking me.
I didn't even realize the time had gone so fast. But let's quickly talk about our media portrayals of nursing. I won't ask you specifically to create a show, but I want to hear, just because I know we're out of time here, but I want to know if you could create your own show, or, if you've seen any shows in the past, what have been your thoughts about them, shows that feature nurses? And what would you do to change?
So first, I have a big handicap in that I don't watch TV and haven't for 20 some years. So
there's nothing wrong with that. I'll tell you.
That's the handicap.
You're not missing much.
I did see Nurse Jackie, and I did read about Nurse Jackie, who I thought was a powerful person, except for they had to make her a drug addict.
Well,
right? Yeah. So what would that look like if she wasn't? What would that, entire show look like if she didn't have the addiction? Yeah. It's not that nurses don't once in a while, but they took the key character and made, had to give her a deficit or a challenge instead of having a nurse stand in her full power. Yeah. So what does a nurse look like standing in his or her own power? Right. And would that be attractive to the real question is, would that be attractive? But can you imagine, we just talked about some moments here, but I would have this nurse, capture both the science, and the art of our profession. Yeah. Just remember, it's the same hand that titrates a dopamine drip and then goes into the next room and is the only hand that's touching a patient who is dying. Yeah. That's the same hand. It's not a different person. Like Our minds can run like ACLS flow charts. Oh, breathing is down. Let's see possible causes. What has happened? What's the medication? Like our mind, and yet then we can stand there with our presence, which matters just as much. I mean, if you could tell story after story after story of these intimate moments, what you would be doing is you'd be elevating the profession of nursing. But you have to elevate both. So I would have my heroine be somebody who is present in these compassionate moments, in this suffering with others, at the same time saying, excuse me, doctor, I don't think that's the right drug. Let me tell you why. Or, look, I'd like to talk to you about your order to increase the Lasix. I'm not going to do that because you haven't run a potassium for the last 3 days and we need to update that potassium level. Do you mind if I do that first and then we'll do the order?
The art and the science.
Yes.
Yeah. Merging both of those things
Well,
together.
that's why I think nursing is so special. Is there any other profession that embodies both so fully? No, not to me. Not even a minister in a church. Right? What profession embodies both? Physicians have been trained, like the Jiffy Lube of healthcare, to assess and to treat and to find the problem as if the body was mechanical. Nurses have been trained on looking at the physical problems as well as the psychosocial, emotional, and spiritual problems. To me, in order to heal, you need to look at everything.
All of it is important. Yeah.
Good luck cutting something.
And then, there are shows out there now that have physicians in these roles where they're holding the hands and they're pushing the gurneys and they're talking through with the patients. And not saying that physicians don't do some of these compassionate work, but we don't see the nurses doing them. And that really...
we're invisible.
Yeah.
We're the most trusted and the most... I'm gonna scream if somebody tells me we're the most trusted profession again. Because do you know why we're the most trusted? Well, ask why. Why are we the most trusted profession? And the only reason is because Cloutier Raphael wrote a book called The Culture Code. And the code in America, the culture code for nurse, is most similar to mother. That's the only reason. It's not because of something we have done. We must change the culture code. Nurse is not a mother. Mothers can be taken advantage of. We love what they do and we trust them implicitly, but if they miss their lunch to give it to me, I don't mind.
Yeah.
Mothers are not highly trained, scientific.
Yeah.
So we have to change the cultural code in order to change the public perception of what nursing is. And that will require a PR campaign, a show like no other. Yeah,
absolutely. Wow. Wonderful. In fact, I don't even know what to say. I'm so full. Thank you. It's been such a pleasure and an honor talking with you. I got so much more than I was anticipating because I was like 30 minutes and we'll be done. But now we're at like almost 50 minutes and I'm still wanting to hear from you. Thank you for sharing all of that.
Well, thank you for asking.
And that wisdom. Where can people connect with you?
That's LinkedIn. It'd probably be the best place. I don't have a website anymore. I will give you the link for my TED Talk and the link for The Dauntless Nurse, which is a book. It's a communication confidence builder. It shows all nurses how to stand in their power. It's on Amazon. Yeah. And but LinkedIn would be the best place to connect with me.
Thank you so much. I will share all of that in the show notes. Thank you guys for tuning into today's episode. Please like, share, and subscribe. Let's keep leading. Let's keep advocating. Together, we can change the narrative of nursing. Until next time. Bye-bye.
Thanks for hanging with me till the end. I hope you gained some valuable insight into the world of nursing. If today's episode inspired you, please like, subscribe, and share with someone who needs to hear about the amazing work nurses are doing. Let's keep breaking stereotypes and reshaping the narrative together. I'll see you next time.